Now we're going to begin the first of four sessions on four different chronic disease topics that were, quite frankly, arbitrarily chosen so that we would have a focus for the discussion. But as you remember this morning's talk about multimorbidity, people don't have just one condition. So keep that in mind. These are just focusing topics, and I'm sure we'll broaden the conversation. And the other thing I want to mention is all the things that have been talked about, shared decision making, health literacy, and a wide variety of things. We don't have a specific sessions devoted to each of those, but I think they're the warp and the woof that runs through every one of these topics. So I'm going to turn it over to LJ to introduce the session.
So yeah, good. This is on. So we're going to talk about self-management support here, and then we're really going to turn it over to Joe and Rod to talk about, what does that mean in the patient-physician partnership? How does that really play out? Because that's where we're really going to find out how to do this. And so self-management support, there's the definition up there. It's more than education, handing out education materials. It's really putting the patient in a central role to manage their illness and make informed decisions about care and to engage in health behaviors. Why is this important? Patients make the decision, the ultimate decision. We can do a great job in the hospital, in the exam room, trying to make the best case for what we want to have happen. But it's ultimately the patient who's going to put things into action. Patient self-management's inevitable. I mean, we all manage our own health system. And Kate Lorig, I don't know if any of you are familiar with the Stanford Living Well program. We've been doing that in Oregon quite a bit. And I sat on a panel with Dr. Lorig a while back, and I like this statement. She says it is impossible not to self-manage. One can do it better, or one can do it worse. And our job is to see where we can go with this. And we've really changed how healthcare is delivered. I mean, a long time ago it was mostly acute illness. When I started in primary care, I could see 35 and 40 patients a day. It's now not possible to do that. The emphasis on preventive care and chronic illness care, there's too much to do. I'm totally zapped after 15 to 20 patients, and I'm really drained. And it's just a complex world, and so I'm finding that it's the more we can get a team to deliver this care, the better, and the more the patient can be activated, the better it is. And this statement that patients are experts about diseases, I mean, we're experts about diseases, but patients are experts about their own lives is really true. And it takes a lot of time. We've medicalized our lives so much that this systematic review of patients with two or more chronic illnesses, I found impressive. That patients and their informal caregivers spend 2 hours a day on health-related activities. Wow, we got to somehow change that so that you can be doing other things. And we really don't understand this, and we don't understand how this burden impacts patients' lives. Sometimes patients' lives revolve around just kind of getting the medical issues taken care of, and there's got to be a different way of living here. And so to that end, I'm going to have a couple of people talk, and we're going to put the patient first. I think Joe's going to go first here and talk about his perspective. You want to be up here?
I don't care. If you all hope you can hear me. My name is Joe Check, and I'm a patient onto it. And my only interface, as I said earlier, with the medical facilities and practices is as a patient. Briefly, I'm a retired chemical engineer. I consider myself probably a very typical patient for what you run into. I'm overweight, out of shape, arthritic, diabetic, high cholesterol, and elevated blood pressure. So as you can see, I have a lot of opportunities for self-management. And I want to basically talk about one of the things that comes around onto it is basically attitude. And for myself onto it, when it comes down to attitude, it's my viewpoint onto it for the ones that are my various conditions that are being treated by prescription pill medication onto it, is that I take those pills as directed. Failure to do so, in my viewpoint, because I've been paying my health insurance for the past 20 years, both medical and out of pocket. It's a waste of my time and money. The physicians out there, well, you get compensated for your time talking with me. So it's a burden on me. What I do expect from the clinician onto it is explain to me why I have to take these medications. What's the expected results of these medications? How are we going to test it? As I said, I'm an engineer. I love numbers. I love cause and effect. And so, yeah, we're not a mass of numbers out there when you take that file folder out onto it, but numbers are a way of measuring whether or not we're making change. So that's my viewpoint on attitude. How we all as a patient, how I as a patient goes in and confront what is happening with my own body is okay, and I'm going to get depressed, whatever onto it, is very important. What I expect from the doctor is to tell me we're not seeing the changes we're looking for. I'm happy to say that right now, all of my conditions are well managed, and I'm very happy with my physician. But I had a situation with the prescription meds that I was taking, that I couldn't get my prescription refilled. And the physician I had at the time, I finally got a hold of him. He had to call the pharmacy up and say, okay, yeah, reissue onto it. And about a week and a half later, I went in to see him, and he said, well, if you miss 3 or 4 days of your medication, that's not really any problem. I said, well, then why the hell you put on the medication that, you've got to take this twice daily on a timely fashion? If it's not important, why am I taking it? And that was a viewpoint from him that really perturbed me. What I want to talk about next is I'm a diabetic. I've been on long-term insulin for about 4 years now, and all of a sudden we're starting to see that my A1C tests are going up. Okay, well, we'll address that. I'll change my eating habits, try to increase my exercise onto it like I've done in the past to bring them back down. This last series of tests couldn't, had no effect. So it was finally recommended that I go on to the short-term insulin, Novolog, after meals. And my physician onto it gave an initial start onto it, and then says, well, we have a diabetic program, that we have a diabetic nurse onto it, that she will work with you to adjust both your insulin levels. So went and met with her a number of times over a 2-week period, started changing the amount of Novolog I was taking and the amount of Lantus onto it, and basically just kind of went on for about 3 weeks and not really achieving the blood sugar levels we wanted. I was getting a little frustrated. The diabetic nurse onto it, which I wholeheartedly support, says, well, no, we need to stick in there and stay with it because it takes some time for the body to react, and there's a lot of variables that we don't know about. And we met, as said, over the first 3 weeks on a weekly basis. After that, we communicated on a weekly basis by email, sending her blood sugars review, call back. She'd bounce off to what she was recommending with my physician onto it. And it took well over 8 weeks before finally get them down to seeing the changes in results of what we want to achieve. If it wasn't for that resource of having somebody other than my primary care physician to go back to, it was a resource recommended by my primary care physician, I don't know if I would have got my blood sugars under control, because I was getting to a high level of frustration, basically, onto it, because I was not seeing any changes. And I'll be honest, that's irritating for a retired engineer. I'm used to seeing cause, effect. Hey, the human body don't work that way. Dumb, but that's the way it goes. So, you know, I'm basically now, my blood sugars are stabilized. I am looking forward to the next A1C test, and I highly support Wanda, my diabetic care nurse, onto it, because without her support, follow-up onto it, I'm not sure where exactly I would be for the management of my diabetes. The rest of them conditions are easily adjusted by pills, but diabetes, I'm finding onto it with the needs of insulin, is a very high demanding self-management program. You need to control what you're eating, when you're eating, and make sure you take your meds on time into it. So for your clinicians out there onto it, and this is something I feel that if it was put back onto my primary care physician, it'd chew up way too much of their time. So it's a support not only to me, having Wanda, the diabetic care nurse I'm working with, but I look at it as a support of the medical organization I'm currently working with. I'm getting little signs held up here onto it. I have to credit, you're keeping right on schedule. I was warned not to talk too much. So, I'll throw out if anybody has any questions for me, but we only got a minute or so. Oh, I'm sorry, we're going to end up having a panel discussion. Please hold all your questions.
One of the problems is when we start engaging our patients in the decision making is they come up with things that we hadn't expected or thought about, and then it takes us off guard. So I'm a family doc in Toma. I'm going to base a lot of what I'm talking about on a workshop that we participated in about a year ago to help AHEC, or the Agency for Healthcare Research and Quality, design a toolkit, an online toolkit they had to help with self-management support, and then use some of those observations to reflect on how it affects practice as well. Most of what I'm going to say has already been said today, and the rest of it's fairly obvious, but at least I'll have some different pictures. And this one really scares me because I'm starting my talk off just like Attorney Neese did, and so, I'm sorry, Attorney Gaines did, so I'm starting to think like an attorney, and that worries me a little too. So as we were going to this workshop, I understood what self-management tools I'd been using and how they developed and evolved over time, and really understood what they needed. Unfortunately, after we got involved in the process, everything started changing and took a lot of turns, just like a Stephen Sondheim play does. You know, a funny thing happened on the way to the forum, or the clinic in this case. Maybe familiar with other works of his like Into the Woods or Sweeney Todd. There's a lot of twists and turns and unexpected things that happen, and the same thing happened with our workshop, and the same thing's going to happen in practice as you engage some of these self-management tools in the support process. The first thing is incredibly obvious. People are different and they have different perspectives, and yet we want to take the same tools, we want to take the same resources and implement them in the exact same way, and it doesn't work. At this workshop, for example, we had really a broad spectrum of people. We had people from northern Wisconsin and rural Wisconsin and inner city Milwaukee, and believe it or not, we're not all exactly the same and don't look at things exactly the same way. Gee, that's a surprise, but we were being asked to do that, and we tried to do that, so we just have to keep that. What I'd really prefer for this slide is the old Sesame Street song. That's about the size where I put my eyes. That's about the size of it, and it's just about perspectives. So when we go into it, we have to use adult learning techniques. And adult learning is not like the learning we do in school where everything's linear and just continually builds. Adult learning, you start with some basic knowledge and some basic concept, and you've got a lot of holes like Swiss cheese. And my family lives in Monroe, so I had to include Swiss cheese. And just for those of you who don't know it, no two Swiss cheeses are exactly alike. So those holes are in different places. And what we have to do is find out where those holes are so that we can help fill in those knowledge gaps. And I've got a Norwegian heritage, so Edvard Munch has to show up as well. Fear works. When we're in our training, we're taught fear doesn't work. Don't use fear techniques to get patients to change or to buy into what you're saying. Smoking will kill you. Well, that's obvious, and that doesn't work. On the other hand, they want to know, what are the long-term consequences? Am I going to be able to continue to walk? Am I going to be able to, are my kidneys going to be working in 5 years or 10 years? They need to know what some of the long-term impacts are of their health problems, their chronic disease conditions. And as we use big data to help us create better models, and then we can plug in individual data points and individual lab values, we can start to help people project where their disease is progressing to, and we can also find out if we make a change here and we improve their renal function, that can improve their long-term welfare and their well-being. So fear in the sense that, yes, you're going to die, doesn't work, but helping people understand what's going to happen does make a difference. And that was really brought forward by some of the participants in the group. They said, if they told me that I might lose my feet, I'd have listened a lot more carefully. And as clinicians, we know that that's a part of the disease. We forget to convey that. And again, chronic illness causes grief, just like death and dying. We have to, once we throw these diseases at people, we have to let them process it. Recently was looking through a chart for a colleague, and they were upset because they found their doctor put chronic kidney disease on the chart, and they hadn't discussed that. And that impacted them more than diabetes, hypertension, hyperlipidemia. All of a sudden, they started making changes, but they had to process it. So they have to go through this process. And until you get somebody down towards the acceptance range, they may not be ready to listen and participate in some of the other parts. This is Psychology 101 from college, or probably senior high school now. But remember, again, very basic stuff, but there's imparting the knowledge. People have to know and understand, but then they have to internalize that information, and they have to buy into what's going on. And only then are you going to start to see some of the behavior changes. So you have to find out where people are at. And as clinicians, we also have to find out where we're at, what we know about people, and what our attitude is towards them, and what we're willing to do to work with them. And finally, we can get to shared decision-making once we've gone through that process, and we've thrown this tool around. We often think of it as, okay, let's sit down and decide where we're going to go with this disease management, and then help them move forward. But it really starts back at the ground level, where we have to know who they are, what their values are, what their perspective is, and then we can move forward. So shared decision-making isn't just the end product. It is coming up with the question. It's not going in with the question. This slide is not in support of motivational interviewing. Recently, I was having difficulty helping people achieve values that we as a system thought that they should achieve in terms of lab values and such. And one of my leader people, I hate to use the word administrators, said, well, use motivational interviewing. Like you take motivational interviewing and it's a procedure like excising a mole or sewing up a laceration, and you just plop it in and things happen. So to many people, they think motivational interviewing is coercing people to do what you want them to do, and that's what motivational interviewing is becoming now. So I don't like that term anymore. That's my editorial. So what's our clinician's role? We're a knowledge resource. We can both provide knowledge and direct knowledge. It is our job to diagnose. When you walk in and talk to your patient, say, well, what's going on? And they turn it around and say, well, you're the doctor. You have to decide. I guess my spell checker wasn't working. So we have to diagnose, but we have to help educate. We have to direct them to resources. And so when Joe found Wanda, that was a load off my shoulders. We have to direct them to the appropriate resources. And we can then empower people to take care of themselves, which takes a burden off of us, for us to try to do things that we really can't do anyway. We then are empowering others to do things for themselves. And after that, we can continue to encourage them, give them support, and then finally we can take those shared goals and help people achieve their ultimate destination, which really isn't a finished product. It's an ongoing process. And I know that's nothing real profound, but sometimes it helps to go back and just review the process and reflect on what's happened.
So we've got a lot more to hear from Dr. Erickson and Joe in a minute, but I wanted to remind you, you're at a research conference. Do you know that? You're at a research conference. I mean, this is about, and you think, wow, this doesn't seem like a research conference. Why is it a research conference? Well, because research is about generating new knowledge. And you're beginning to think about what is some of the knowledge that we need to generate here. And you're also with a practice-based research network, REN. And they're bringing research from academia into the community, because that's where we're going to really find out what works. And so I want to just mention a couple of things here, because I think a lot of it is about linking questions from communities to answers from the communities. You have the answers, and we want to know what the questions are, because sometimes we kind of think we know, and we really don't know. And this has limited our ability to make a difference. And we use these two facts quite a bit. And I think it's because we don't have patients that have been involved in the research enterprise. And we really haven't had practicing clinicians involved in the research enterprise to really impact these two statements here. I think we have an opportunity to make a difference here. And research networks such as REN, the setting, your practices and your communities are extremely important to us. It's the real world. It's where things happen. There are 113 touches in a primary care office for every touch that happens in an academic health center. But where do you think most of the research is done? It's done in the academic health center. We really need to be doing this at the community level. And as we think about this in terms of self-management support. What do we need to know about self-management support? I think we've heard it's incredibly important, but it's also really difficult. This figure here I like a lot. Take a look at it. I mean, you've got on the y-axis the focus on self-efficacy, the focus on technical skills at one end, information provision and behavior change on the x-axis. That lower quadrant with written information, electronic information, online courses, that's where I used to be. You know, it's the easiest thing to do. Let me pull out a handout for you on low back pain. It doesn't take much kind of energy, but I think we're moving beyond that. We're moving into care plans. From a behavior change package, it's group education and self-monitoring of diabetes, you know, kind of knowing where you're at with your diabetes. And then the telephone coaching, goal setting, and motivational interviewing and group education are critical pieces. And a number of you in Wisconsin participated in studying this through InSteps, which was a program that Don referenced, and his Colorado group led us in boot camp. They decided to move boot camp out of Colorado into 3 other states, and so we got a chance to experience that. And Joe and Rod were a part of that boot camp in Wisconsin, and then we heard from Milwaukee, Richland, and Iron River, is it? Were the other places that participated in that. So I've got a question for REN practices. These are some questions I've got for you, and maybe you can kind of help answer them, and Joe and Rod can weigh in and stimulate some of the discussion. Who is primarily responsible for driving self-management support in your practice? Is it the clinician? Do you have a nurse or a medical assistant that's kind of leading this, or somebody in your front office, you know, or are you all doing it? Or are there just pockets of it that go on? What self-management support tools are you using? We studied this with InSteps, and we'll show that in a minute. And how are you using health information technology to facilitate self-management support? We really do have some amazing tools with the medical record these days that we didn't have before. Patient portal, the role of asynchronous communication, where patients can send a note to me and say, you know, I'm kind of wondering if I shouldn't be doing this. You know, not everything takes an office visit, and if we're going to encourage patients to do self-management support, we don't need to kind of put them in a straitjacket of having to schedule an appointment in the office. There are other mechanisms for doing that. And, you know, and that's where how patients are informing us about self-management support is part of that as well. This is a slide that, I don't know, how many of you have seen this slide? Anybody see this slide? Yeah, this is an incredibly important slide, and it was in Health Affairs in February 2013 that showed that the reason there are patients in this room, because patients are important in all aspects of care. Direct care, we're even involving patients in kind of how do we run our organizations, and even in policy making. And so factors that influence engagement, the patients are there to tell us about the beliefs in their role, health literacy, and education. They're incredibly important. I think that in the research enterprise, we need patients. Because as I mentioned, research is about generating new knowledge and generating the truth. And patients are going to provide the true north for us and let us know that we're heading in the right direction. So I'm really glad to have patients here. So as part of this workshop that you folks, 4 practices in Wisconsin participated, and Joe and Rod participated in, we kind of wanted to learn what did it look like through the eyes of people in the practice, and this included the patients. So each practice was to have a clinician, a care manager, and 1 or 2 patients. Did you bring more than that, Joe, or is that pretty much? Yeah, and so I think that was pretty much it. So we had about 4 practices, about 16 participants. And this, I want to just highlight what this group, it was really a powerful group. It was a powerful group, probably the most, I got to tell you this story because it really meant a lot for me. Kathy O is a patient in the Willamette Valley, and her doctor, Dan Paulson, who's, by the way, a graduate of the University of Wisconsin Family Medicine Residency Program and practices in Springfield, was sitting to her right side, and we were having lunch. And she was talking about her relationship with her doctor. And she said, yeah, my doctor looks after me, even to the point where he made me give him my cookie because she's diabetic. And he was just looking after her over lunch. But it brought the relationship to a whole new level. I mean, this boot camp process was pretty powerful. It was pretty moving because it was kind of everybody got a chance to input. And so these things that you're seeing up here, everybody weighed in on equally. And so I just want to highlight the things that got a lot of dots on this because I think it characterizes what we're about. Family takes care of family. Don mentioned this, and I feel really strongly about this. Patients care about their practices. We've done a number of boot camps with patients where they say, why are you here? Because I want my practice to get better. They want to take care of you. Doesn't that seem strange? You kind of think of yourself taking care of patients, but your patients want to take care of you as a practice so that you can be really good. You can't fix everybody, fix what you can, keep it simple, trust, empowering the patient. I like this one, the doc and patient meeting in the middle. Experience-based care, not just evidence-based. Peer support groups were huge. That was, I don't know if it turned out, Don and other ones, but that was we had a couple people that really wanted to have peer support groups. And one patient said, how do we go beyond the numbers? I don't really want you to keep talking to me about I'm not meeting my hemoglobin A1C targets. I'm tired of hearing that. I want a different message and a different communication. It starts with the relationship and trust. I think these are powerful messages, and this came out of that boot camp process, and we have a lot to learn about that. These were the tools that were selected. Wisconsin's got the problem-solving worksheet. Don showed you the Colorado one, taking charge of your health. They went rogue and did their own thing. We took and modified a pencil drawing of a figure, your diabetes health guide, and one practice redesigned it and made it this way, and then the Iowa group did the personal action plan. I want to mention the importance of, when we talk about self-management support, it's more than the medical office, it's about community resources. And Rebecca Etz is a health services researcher in Virginia that described this bridge where you have primary care on one side and community resources on the other side, but we have troubles getting patients across that bridge. And we can't provide optimal chronic illness care without knowing how to negotiate that bridge. And we haven't figured that out. We failed. We have failed to figure that out. And we kind of described some of that in the ARC website here where we're at. And these were some of the priority questions that I just want to leave you with to think about. These were 3 questions that we outlined in terms of addressing preventive care, but they apply to chronic illness care. What is a setting? What are the characteristics of the setting is important in figuring out that bridge, both at the community resource level and at the primary care level. So settings, the context. And then the next is, what's the best methods and strategies for studying this? What are the best approaches to studying clinical community resource relationships to deliver self-management support? And third, what are the measures for evaluating the effectiveness of the clinical community resource for delivering patient self-management support? So those were 3 questions, broad questions that I wanted to leave you with here and to kind of hear about. And I think we're at the point where I'm going to maybe turn it over and ask Rod to kick off what are some of the issues around the clinical and community resource piece for you?
So in 30 seconds, I'll describe how to integrate primary care and public health. Maybe not. Obviously, one of the big issues is how do we integrate and combine public health, community health with primary care. And I think Paul Hunter kind of alluded to some of that. We actually are engaged in a process now with our public health departments and our clinic to look at those problems that are identified on the community level as being major problems, and every community now has to define those. And it really starts back to meeting. I mean, you have to do face-to-face meetings and make those personal contacts. And that process has to include the people most invested in it, meaning people who are patients, the healthcare providers, and the public health people. So, for example, we have an opioid misuse reduction initiative, and we have public health people coming into the clinic to describe what community resources are there, and in turn, we're letting them know, what we're trying to do, so that we can all be on the same page and not duplicate resources, and fill in some of the holes in the Swiss cheese. Some of the self-management strategies, though, I think Joe really alluded to those much better than I can. It's pulling together your team. Our diabetic educator, Wanda, that he alluded to, is a saint, and she's a savior to me. She can just spend a lot of time, and she has also a lot of expertise. She knows what problems people have trying to manage their diabetes, for example. And for me, it's like, okay, your A1C every 3 months. I mean, that's what I'm seeing. I'm seeing your blood pressure every 3 months. I don't know what it is all those other 89 days out of the cycle. So when we live with somebody for 20 minutes every 3 months, we sometimes don't have a full picture of what's going on in their life, as shocking as that may be. And so having people who are actively engaged and can sometimes act as a translator between the clinician and the patient is really, really important. Sometimes that's our office nurse, sometimes it's a receptionist, sometimes it's the diabetic educator, but we have to know who's on our team and how they're interfacing with people.
That's great to think about building a relationship and develop some trust. I really want to hear from patients about what do you need to have patient self-management support take place in your lives. Joe, do you want to accentuate some of what you said?
For me, to be able to self-manage my diabetes onto it was to be able to contact people. And basically, Wanda, my diabetic nurse, onto it. It wasn't face-to-face. It was the clinic that I go to, making the resources available that I could communicate by email through a secure portal onto it for things that are not critically important. Something that's critical. Hey, I'm going to the ER, or I'm going to make an appointment immediately onto it. And it wasn't immediate feedback needed. It's something that, as time became available for her, get back to me in 2 days. Where are we going to go from here? Do I keep my same levels onto it? And it was the resources that were made available to be able to do that communication. Made it much easier for me to self-manage. Because then when I get back, I said, okay, yeah, and the other key onto it is part of the self-management. It was never dictatorial. This is what I recommend we do. These are the reasons why I'd like to do it. Do you concur? Do you see? And it was mutual, mutual agreement that, okay, yeah, let's go this way. Let's see what the results are going to be. And it was that kind of feedback that made it very actually enjoyable. In fact, Wanda was spending so much time answering emails and all that, I flat out asked her, are you being compensated for this? Because, I was used to more so, okay, make an appointment, go in for the 20 minutes onto it and get the blessing and walk out onto it. So that's what it is in regard to my diabetes self-management. The self-management for the high blood pressure, cholesterol, and the arthritis and all that onto it, that's by prescription meds. And as long as I got the prescription meds, it's my responsibility to do it. And that's, I have other friends onto it. I think it's something, if possible, you as the clinicians out there should try to stress is that you all don't really do the management. It's the patient that's got to do the management. And if they fail not to do the management, all you are is a teacher. You're reporting on the report card. They don't work out too good because you're not doing your homework.
Actually, Joe brought up an excellent point. At the end of the day, it is going to be self-management. And I guess our role as clinician is to decide whether it's going to be engaged self-management for the patient or simply neglect, be it benign neglect or not benign neglect, because we're not the person who's there doing it day to day. And when we put people on these fluid restrictions or restrictive diets or you tell them to go out and run 14 miles a day, it's going to be them who has to either accept what is appropriate and what's ludicrous and move forward with it.
So we're, is it Q&A now? Okay, so it's Q&A. So I'd like to hear some other voices here. Yes.
I was sort of a little bit disturbed at the comment that you don't have 3 months worth of stuff to look at. And my question would be, why not? Because with some patients, you do have that information, you just don't use it, when you get the information out of the cloud, or if you do a 3-month blood glucose meter type reading or CGM. And in my experience and having a lot of involvement with the healthcare industry, it's available and not used. So my question is, has the medical profession has made a decision that that's just a waste of time? Or are you just not aware that it's out there?
I'm sorry, what information are you referring to?
3 months worth of blood glucose and CGM data?
You mean from a patient sends in?
Yes. Well, it's not sends in, sends to the cloud, and you've got access.
We have to find ways to process that quickly. For example, in Joe's case, the diabetic educator is looking at that, and then she's forwarding it to me, so I'm aware of it. And I can process that stuff in 2 and 4 week bits. When I get 90 days of data on repetitive days from different people, it's a challenge. So we have to find ways to process that and have people help us process it. But yeah, I mean, I'll get like 40 messages in my box a day to respond to, and that's in addition to the patient care. Just like LJ, I'm not as young as I used to be, and I can't see as many patients as I used to. Is that what you were referring to when you said you can't see as many patients?
Yes. I can't. There's a lot to process through it. Are there some, we've got patients here. I'd like to hear from patients. What do you need for self-management support, or,
Before you go there, I have a question to follow up. I wanted to thank Rod and Joe for a great presentation. From a research perspective, I think a really critical junction is the inclusion of guidelines and practice, and then why they don't get done, like you mentioned. And Joe really hit on a really critical issue, which is if he doesn't understand what the medicines are for, then he's not really going to implement them. And you mentioned the use of technology, and I wanted to talk about that a second. I've studied the integration of guidelines into practice, and I think the biggest change that I've seen as a clinician and researcher in the last 15 years is how technology's really interfered with practice, not the record, but the internet. So literally almost every visit, I have to undo what people have discovered on the internet. And the biggest change that I've had to do is literally walk patients through their medicine every time. Joe wants to know, when he's got 4 or 5 medicines in his hand, they're all white pills, what each of them do, or he's not going to take them. And I wanted to know what Joe thinks about that. And I can tell you that consistently, over and over, almost 100% of patients that I talk to, when I say, do you know what this medicine does? They go, no. And I go, do you know what that medicine does? And they go, no. And I say, all right, look, here's what these medicines do. And then they've read on the internet. And I'll tell you the other thing is we're hearing from patients that are a bit older, and they want continuity. But the millennials, I'll tell you, it's a different world for them. We're going to see a completely different change. They want acute care, and they want to read about it, and they want to get answers on the internet. And things are really shifting, and we have to be prepared for kind of a whole new world. And I'm not convinced that technology is really the answer for information. What I'm hearing over and over today is it's about relationships. That's what I'm used to. And Joe has said this repeatedly, that he wants to hear it from his provider. So I'm really interested, because that's what I heard from both Rod and Joe. The information that people get from the internet is consistently wrong. And so I can tell you from things like statins, for example, or ACE inhibitors or something, I have to constantly correct it. So I think the future is still relationships. And I wanted to hear what Rod and Joe had to say about it. And when we do research on what's going to improve adherence of patients on chronic conditions, I really think it's going to be about how we continue to build this shared medical decision making, and it's not going to be technology and handing out information and getting patients on the internet, in my experience.
From my viewpoint onto it, the technology I'm talking about is the communication channels between me, my physician, the caregiver that I'm talking with. Yeah, I'm a retired engineer onto it. I used to write computer programs onto it and so on and so forth out there. And what I chuckle about now is a lot of the information. Let's take an example onto it. Just look at the ads that are being pushed on TV. Every week there's something new that, it's going to help me, it's going to help my diabetes here or there onto it. But you need, from my viewpoint, the clinician needs to say, well, do you need that? Is the medication we're currently on working? Are you happy with it? Because you look at one meds onto it that 2 years ago was the greatest thing in the world. Now it's the cause of lawsuits going on. I look at the commercial, 1 minute long, 15 seconds. They tell you about the great things that this is going to do. Yet the next 45 seconds is all the possible side effects. I'd rather have the disease. So that's the type of communication onto it. Is I want somebody that I trust to help me understand my medical conditions. I'm not looking to live forever. I just want to live well while I'm here. So,
I can't remember your exact question, but I think I'll reflect upon, the gist of it and then throw out a question, because I too would like, yes, the millenniums are certainly different from the boomers, who are different from the greatest generation. But we're not all that different, because we didn't behave that much differently than the millennium, other than our technology was different when we were that age. And, we were quick relationships, move on to the next part of our life, and then longer term relationships became more and more important. And so believe it or not, we're not as different as the media makes us out to be. There are some differences, but not as much as people make it out. But it's not good news to say we're not that much difference. But those of you who are consumers of healthcare, for us providers, so for us who are clinicians and researchers, what are some of the questions that you have for us that you would like to see more research? I've heard one and that is, what is the impact of continuity? How do we measure it, and how do we provide it, both through ourselves and through proxies? But what are some of the other questions that you would like to see answered? And the way we answer questions is through research, or we look them up on the internet.
Hi, you just asked that question, but that's not what I was going to say, so if I could just make a comment. I really appreciated your presentation. It resonated with me because I'm not a clinician, but every day we engage the community and we ask them what they need. And having that relationship with them, empowering them with the knowledge so that they know the right questions to ask a clinician is very good. And self-advocacy is very important, and that's what I feel that you're doing up there. And if they can't advocate for themselves, having someone else be an advocate for them so that they know and are equipped with the right questions to ask. And so when you say that you convey a message and explain, why a certain regimen or medication is needed, that's very powerful and it's very useful. And so from my perspective, not being a clinician, I would think whether you're a clinician or a patient, anyone giving you the tools needed to equip yourself to improve your health is very knowledgeable and is very helpful. So that's what we have seen in the community being very useful. We see people who don't ask questions now asking questions and becoming more knowledgeable about their health. And I think that's what's most important.
I had a question related to one of the pearls you had talked about, and one of the things that I see in practice and we're discussing a lot in Wisconsin right now is burnout of providers, and not only of physicians, of advanced practice clinicians, but even of staff, just because of the task and the workflow type of things. Patient-centered care, our homes, actually because of many of the protocol-driven items, or even the number of items that we have to remember and to manage and to make sure that we're notifying patients, have a tendency to burn us out with the tasks rather than coming back to that personal relationship and some of the things that will help people understand and move toward better chronic disease management. So my question for you in this particular research venue, when you're looking at the boot camp model and some of the other things, is what was the impact as far as task management and the caregiving team, as well as the patient, as far as what's the ratio of tasks and burnout on the caregiving team side versus the impact related to the patient and the benefit? Has there any studies been done related to those type of things?
So, John Beasley, you want to help with that question about burnout and workload?
You probably don't want me to get started. It's a real issue. I attended a meeting at the State Medical Society yesterday morning. There was an entire task force looking at this. There was a study done, commissioned by the AMA, done by the RAND Corporation about a year and a half ago, which came out again showing roughly 50% burnout rates, and a lot of it being related to the ways in which we're using technology, some of which interestingly may be quite subtle. There's a whole phenomenon, and those of us who are from the 60s and 70s remember the whole thing about going with the flow and being in the zone and this kind of thing of true immersion in a task. And when we're having to shift our attention from the patient and our interaction to the technology and entering an order for an x-ray or whatever, this can be very disruptive to that flow phenomenon. I mean, it's common whether you're a tennis player or downhill skier or concert violinist or whatever we do and we're engaged and engrossed in, it's very important that we be able to sort of stay focused. There's been shiftings of tasks, again, in ways which I think disrupt our relationships as well as just extending our work hours.
So this is a really complex issue, and there is a lot of fatigue. There is a lot of burnout, and so I think we do need to begin to study this question. And we've seen with practice transformation, those practices that struggle are the ones that are most physician-centric. That physicians are a barrier to transformation. And the practices that tend to do better are those that have really high levels of respectful communication and teamwork and trust in each other. And how do you build that these days? Because I think we do have a new model of care, and it's a team-based care. We have a new model of care where the patient's having increasing responsibility. And I'm actually hopeful that this is going to be capacity building for practices, and we have to figure out how to harness all the information that comes our way. And I get concerned about the patient with a sprained ankle going in and telling me, look, I just got screened with SBIRT, I got screened for depression, I just came in with a sprained ankle. So we haven't figured out quite how to make the system work, and so we've got a number of workflow issues around that. So I don't have an answer, but I think we have opportunities to move beyond burnout, and how do we study that is really, really important. Please.
I think we almost just skipped over a research question. We had a discourse here about observed differences between millennials and older generations and how they are accessing healthcare. And I don't really think that we have a definitive answer on those people that grew up with information devices that are fundamentally different than the ones that older generations grew up with. And that kind of shift in culture and the way that people access information may be more profound than we think because of the time in their lives that it was introduced. And I think that's an opportunity to maybe prepare for a change that could otherwise be unanticipated and create more difficulty.
So what do you think we might be able to study, say, using smartphones and text messages to see how things might be different?
Well, now with the newest iPhones that are released, I can simply say, "Hey Siri," and ask a question and have an answer provided to me. Now, what is the source of that answer? We don't know, but it's being provided nonetheless somewhat ubiquitously. And that is a real thing that's happening on a large scale, and it's being deployed at a time when young people's minds are still forming in the way that they work. So, obvious challenge to that, young people don't have as many chronic conditions, but those young people will have chronic conditions, and by that time they're going to be older, and these methods of thinking and accessing information are going to be so ingrained that it's going to simply replace what we observe now.
I'll put my engineering hat onto it. What you're looking at there is a change in culture, how information is available. Yeah, it would be very interesting to have a study onto it to compare millennials onto it as to when is the onset of a chronic health disease, diabetes, high blood pressure, whatever, versus the older generation, my generation, onto it. Can't say my parents; they're not around anymore. But it would be a relatively, from my viewpoint, Is everybody awake now? Okay. It would be a rather long-term study because, when does the onset occur? I know there's a lot more information out there onto it. I go around and around with my nephew onto it and some of my grandnieces as to what, what they're checking into. You're hardly to the point where I can clear my throat and say, oh, you could have one of these 14 diseases that they found on the internet. And I said, well, if I get tested to it, yeah, maybe I might have it, but I'm not going to subject myself to all these other tests. Now, trying to prevent it, I don't know. I think it would be a very interesting study, but I don't see it something that could transpire into 3 or 5 years. It's going to be a very much longer term study.
I want to thank the panelists. It's time for lunch. I hope this conversation continues. I'm not here to cut it off. The panelists will be at lunch. I'm really tickled to begin to see these things coming out, and I had no anticipation of some of these questions that we've debated for which there's differences of opinion and no evidence. So I think that's what we're looking for during this conference. So I want to thank the panelists, all three. I think it was very rich.